Hello, and welcome to another Purview webinar. This is the first in an ongoing series of 3 webinars dealing with the issue of oncology and second opinions in oncologic situations. My name is Les Trackman. I'll be your host for today, and I'll introduce our guest in just a minute. First, a few ground rules. For all of you participants, your microphones will be muted. We also don't get to see your video screen, which is a disadvantage for us. The session will be recorded. So for those of you who have colleagues that would like to view and listen in on what we're doing, you can let them know about that, and they can get that off of our website shortly after the webinar is completed. If you have any technical issues, unfortunately, we have a bunch of people on the line, so technical issues we won't be able to deal with one by one. So if you have those, my best suggestion is you log out and log back in again. That usually fixes the Zoom problem. And then if you have questions, and we will take questions at the end of the session, you can put them in the Q&A section that should be near the bottom of your screen. If you log those in, we'll see them when they come up, but we're not going to deal with those until the end of the session, unless something egregious happens in between. So as I said, again, my name is Les Trackman. This is the first of our webinar series that we'll be doing the next 3 successive months. And this is about oncology. So as we all unfortunately know, cancer impacts way too many people in our lives. Each of us has been affected either directly or from a friend or a family member who's been impacted by the disease. I've actually had 2 friends in the not so distant past who were impacted and who lost their lives way too early. And if you've heard us discuss at Purview, the Mike Shane Memorial Fund, that was my reaction and our reaction as a company to one of those deaths. The treatment of cancer has come a long way in the past few decades, but we still don't have the disease licked. And as a vendor of platforms focused on enabling hospitals to deliver efficient patient expert second opinions in areas including oncology, we've been amazed to see the statistics of how important second opinions can be. The Mayo Clinic, for example, did a study of second opinions it delivered and found that over 80% of them recommended a change in diagnosis or a modification in the treatment of the patient. That's quite a big impact. So what should the patient do and when should they do it? And if you're an expert physician focused on a particular disease, how do you efficiently deliver a second opinion to patients in need, especially when they're not local to you? Those are some of the questions we're hoping to answer in this 3-event series of webinars. Speaking of specialists, I'm honored to have with me today for our conversation, kicking off this webinar series, Dr. Ramaswamy Govindan, who is the chair of Medical Oncology of the Siteman Cancer Center of Washington University of St. Louis, one of the top-ranked cancer centers in the world. Dr. Govindan is a rock star in the world of lung cancer. In fact, so much so that I'm told he is known by just one name, like Beyonce or Prince. He goes by Govindan. In any case, Govindan wears many hats as a professor, a researcher, a physician, and an administrator. In case he wasn't busy enough, he's also co-chair of the groundbreaking Cancer Genome Atlas program for lung cancer, sponsored by the National Cancer Institute. So please join me in welcoming Dr. Govindan. Dr. Govindan, great to have you here. I know we had a chance to chat in the past, and we've got quite a diverse group of attendees who've signed up for this session, either live or the recording. But let me start by asking you, Dr. Govindan, if you wouldn't give us a little bit of background on the Siteman Cancer Center and what you do there at Washington University of St. Louis.
The Siteman Cancer Center is a comprehensive National Cancer Institute at Washington University School of Medicine. It's been in existence for over 20 years, and over the past several years, we have made some groundbreaking discoveries in cancer, and I'll give you one example. As you know, cancer is a disease of the genes that get disordered in the cells that lead to disordered growth of the cells, leading to cancer. And until 15 years ago, we weren't able to map out all the sequences of these alterations, what we call the gene sequencing or genome sequencing. And Washington University was the first institution to map out the entire genome of a cancer tissue from a patient with leukemia back in 2008. My colleague, Tim Laylett, that worked along with Rick Wilson and Elaine Mardis from the Genome Institute then, Subsequently, many of us have led many genome research studies. Some of the important contributions to understand how the immune system plays a role in controlling the cancer was also done at Washington University, chiefly led by my colleague Bob Schreiber. And years earlier, PET scan one of the major contributions to bringing PET scan today happened at Washington University. And even back, if you go back in time, one of the earlier observations of tobacco smoking and lung cancer was made at Washington University many, I would say 50, 60 years ago, before formal studies were done by the British group linking the association between tobacco smoking and lung cancer. And the very first patient with the pneumonectomy, which is removal of the entire lung, who ended up living, happened at Washington University as well. So there are a number of these great accomplishments over the years. And I'm also very proud to say that the Siteman Cancer Center received one of the top rankings by the National Cancer Institute, the exceptional rating, back-to-back, 2 consecutive times over a 10-year period, really reflecting the accomplishments of the physicians, scientists, and the staff. So we are proud to serve this region, this area, and also nationally and globally, really contributing to research and patient care. And so I'm very proud to be part of this remarkable institution.
Yeah, and we're very thankful that that you guys exist and for all the great work that you do there. My understanding is that that the Siteman Center and Washington University St. Louis Medicine, one of the biggest facilities in the world dealing with cancer.
It is. In fact, there are very many ways you can dissect this analysis, and the number of new patients seen here is really fairly high for a single institution, upwards of 10,000 new patients a year. A few institutions in the country go above that. And in addition, our contribution to scientific literature, number of patients enrolled in clinical trials, really is significantly high. In fact, the number of new patients entered in clinical trials each year is significantly higher from Washington University than I would say most institutions in the country. And the number of papers published in high impact journals is also consistently very, very high. And that shows once again a comprehensive dedication to cancer care, from research, bench research, to patient care, and then back from the bench to back from the patient care, from the bedside to bench research, and this kind of a revolving thing that augments wonderful, outstanding patient care.
That's great. And I think we're going to talk about at least the idea of clinical trials again before we're done today. So let's focus in, though, for purposes of this webinar, on second opinions and the idea that these, as we got the statistics in the Mayo Clinic, are really important because they do point out things that perhaps the first opinion hasn't done. But when you get a patient there who wants a second opinion from you, how do you deal with it, or how do you and your other physicians deal with it at Siteman?
I think these major cancer centers play an important role in helping not only patients and their families, but also the treating oncologists in the community. Cancer has become far more complex. Cancer treatment has become far more complex. Cancer has always been more complex. And I have to say that today, the treatment has become, we have very many treatment options. And if you take one disease, for example, breast cancer or lung cancer, it's no longer one disease. There are many different subtypes within that. For example, in breast cancer, you have hormone receptor positive, triple negative breast cancers, HER2 positive lung cancer, breast cancers. So there are various different types. Lung cancer used to be basically 2 diseases: small cell lung cancer, non-small cell lung cancer. Now the non-small cell lung cancer is broken out into multiple different types based on the gene alteration. So it's hard to keep up with all the changes if you're a general practitioner of oncology in lung cancer, breast cancer, colorectal cancer. Well, they do a spectacular job delivering care closer to where the patients live. They would need help frequently, and patients would get comforted that they have been to a tertiary site, seen physicians like me who specialize in one cancer, think about those cancers, do research on those cancers. So I think for patients, I think it's the best of both the worlds. And if they come here and stay here for a particular reason, that's one thing. But my goal is always to give opinions and advice the treating physicians, and work with them very closely to help our patients so that we can avoid coming to major cancer centers, traveling 200 miles to get standard of care therapy that they could get closer home, and also help them come and participate in clinical trials when needed. So this kind of a very close cooperation, I think, is essential in order to help our patients and the community.
So that's great. So we know that there are patients that are very hesitant to ask their local treating physicians, even oncology specialists locally, for a second opinion, or to say that they want to get a second opinion. Many patients hide that from their physicians. But what you're saying is this is more of a partnership. Is that fair?
Absolutely. It has to be. That's the only way I think it'll work for everybody. People in those tertiary centers, if they act as if they are the only ones who know how to treat patients, that really fractures the relationship these specialists have with the community oncologists, who I think, in my opinion, provide an important service, especially when patients cannot travel week after week, 200, 300 miles. So I think this is not so much a competition as much as a close cooperation where the ultimate goal is outstanding patient care.
That's great. So that goes a long way, and it knocks down a lot of barriers that we often hear. So when a patient engages with a specialist center like Siteman, what would you recommend they have ready, available in terms of medical records or treatment regimes that they've currently have? What should they bring with them, or what should they send in advance to you?
Thanks to all the electronic records, Les, now things are becoming far less complicated. I remember 20 years ago, when we saw patients for second opinion, they would bring, huge amounts of paper charts, and we have to flip through in the last minute and try to get this information. Now we have electronically, these records are transferred very effortlessly today, and even images are pushed electronically, even if the systems don't share this information. So there are some wonderful tools that really, they have made our life immensely easy and help our patients and families. They don't have to carry all of them in their hands. But I'll tell you a few things that are important. When patients seek a second opinion from an expert side, it's very important that the expert independently reviews the images along with their colleagues in radiology, make sure that the pathology colleagues take a look at the pathology slides to make sure that we are really giving a comprehensive opinion, not just on how to treat a given cancer based on a report, but ensuring that the finer points are checked. And then there are issues in particular aspects in imaging that I think important to corroborate with the report that are issued elsewhere. And also the pathology slides are reviewed carefully, and if necessary, always, and if necessary, additional tests are performed on those slides. I think it's important that we give a comprehensive second opinion, rather than just going by some printed reports. And that, I think, would reassure our patients significantly and help, give a, appropriate second opinion, in my view.
Okay, so typically you would review their radiological records, so their DICOM images. You'd review potentially their pathology, and in oncology that's pretty common. Do you do digital pathology there, or do you ask for the
happening
blocks?
now? Not as much as you would think. It's happening increasingly, but I think that's absolutely, in my opinion, needs to happen. Instead of taking time for the slides to be couriered and cut again and then take a look, I think now the technology has evolved that I think very soon, much like radiology, we should be able to push all the digital slides across. It's happening increasingly. I don't think it has become widespread. I'm not an authority in this area, but I think that needs to happen more and more. But right now, so for good measure, I think in some instances we do electronic review of these slides, but I think for most part it's still happening the old-fashioned way. But there's clearly an area for improvement. One other thing I want to say, Les, you may get to that later on. How does this partnership work? Once you come to see a second opinion, how does this patient goes to and fro from their primary oncologist and then to the specialist? How does it work? If you're going to talk about that, I'll stay quiet now.
It was a question I was going to raise. You look like you're reading my notes today.
So the thing is, getting a second opinion is fairly straightforward. Calling for an appointment, getting all the records, and having them reviewed. And I think the important part is expert has to do, in my view, and I do that fairly consistently, is to reach out to the primary oncologist. And very often, almost always, I give them my cell number, and so they can approach me directly instead of going through a lot of hurdles. And that also gives them some security. Sometimes patients go back to them, and 2 months later, they have some issues and they want to reach out to you when they're in the middle of a busy clinic. And knowing that they have your number handy and they can reach you within a short time, I think is very helpful. That builds a relationship between the primary oncologist and the referring physicians. And that's how I think the communities are built. And I think that's the expert has to reach out to the referring physician or the primary treating oncologist. I think that's quite important. And I didn't answer your earlier question. Patients sometimes are, as you said, reluctant to get a second opinion because they worry that they'll be upsetting the doctors. I don't know how to reach out to the larger group, but I always reassure the patients who come to see me that, physicians want the best for the patients. And yes, there may be instances where people can get offended, but in reality, I think you want to have a physician who is secure in the knowledge, confident in their abilities, and not be insecure about somebody getting a second opinion. I think good physicians, caring physicians, don't get upset, so to speak, about somebody seeking a second opinion. In fact, many of them get reassured that they get a second opinion that helps them care for the patients even better. And I think they appreciate that. And that knowledge is increasingly prevalent now. Also, as you know very well, Les, patients who come to see me, an expert in lung cancer, do seek second opinion elsewhere too. This happens all the time in major cancer centers, and that's perfectly okay. And I think one cannot be upset about that. But I think the important thing is once you establish the relationship between the expert and the primary oncologist, the patients may want to come back for a second opinion later on once the disease progresses or when there's a change in the treatment plan or there are complications. The one thing I do remind them is when they come back, make sure that they bring those films, and or when they go for a CT scan in a local place, always ask them to put the CT scans or imaging on a CD. They can bring it back to and fro. And I remind patients on this side too, when they come to see me, remind them to put the CT on a CD so their oncologist can have that electronic picture, or we would push them electronically into their EMR system. And so I think this kind of a comprehensive coverage of not only the office reports, but also the information about the imaging, actual images, I think is quite important, even more so when radiation oncologists are involved and surgeons are involved, where they need to have these pictures for them to make treatment decisions. And also I would encourage the medical oncologist to get a copy of those actual films so that their care can be comprehensively, well-rounded.
Yeah, great. That sounds like a commercial for Purview. That's as many of your colleagues there know, we provide that information in electronic fashion, actually cloud-based, so it doesn't even have to transfer, but that's a separate set of issues that we can talk with later. So from a physician to physician, I love the conversation that you're having about this partnership, because one of the issues that many specialty facilities have is that when they treat patients that are out of state, they run into licensure issues. And if you're dealing doctor to doctor, that licensure issue basically goes away. It evaporates because a doctor to doctor consult across state lines in most cases is pursuant to the law, is part of what is permitted between states. So that's great. So let me get to your genomics side just for a minute. So as you mentioned in your introduction, genomics is becoming more important. It obviously is the root of the evil of what happens with cancer. Can you talk a little bit more about that, and maybe even mention the project that you're working on, how that impacts what's going on with cancer?
Sure. I'm happy to, Les. Thank you for asking that question. Cancer is a disease of the cellular genome. I bet there are non-physicians in the audience, so if I can make it fairly simple here, each and every cell in the body has about 20,000 genes. And of those 20,000 genes, about 400 to 500 genes, when they get messed up, we call them mutated, they can lead to changes in the cells. With sufficient amount of time, sufficient number of alterations, these changes could result in the cells completely losing their normal bearings and becoming a cancer cell. The difference between a normal cell and a cancer cell is that the cancer cells keep growing, they break into tissues. Normal cells stay in one place, they only can grow up to a point, they don't move around. And the fundamental alteration in cancer, or what causes cancer, is alterations in the genes. When I say the genes, I want to be very careful. These are genes happening in the adult tissues or the tissues in the body, not necessarily transmitted to their families, the children or grandchildren. And every cancer is a product of altered genes in the cells. And what triggers the changes in the genes? Various things. In some instances, smoking for lung cancer, or exposure to carcinogenic substances in other cancers. In many instances, we don't know what triggers these cancers. It's a natural product of the cellular wear and tear. In the past, when patients came with cancer, we made a clinical diagnosis, we got a biopsy, looked under a microscope, and poured some stains and figured out where they came from, and we called them lung cancer, breast cancer, etc. But today, we don't stop there. We take those tumor tissues, grind them up, open the DNA, map this DNA, and see what genes are altered. Lung cancer, for example, the non-small cell lung cancer, there is a type called adenocarcinoma, cancer starting in the glands of the lungs. And if you look at a microscope, they all look the same, but in about a 15 to 20% of patients, it is driven by a mutation in a gene called EGFR. And in about 2 or 3%, it is caused by a gene called ALK that is altered. They look very different in a microscope, but when you map them, the genes that are altered are very distinct, and the treatment is very, very different. The drug targeting the ALK gene problem will not take care of patients whose cancer is driven by the EGFR gene. So it's really becoming very siloed in that fashion, and the research is progressing along those things or those lines. Chemotherapy and immunotherapy work broadly across various different types, but even there we are trying to figure out why some patients do better on immunotherapy or chemotherapy than others. Again, the answer is going back to understanding how the genes are altered, and now we have tools and technology to really understand the gene alterations. By the way, the fact that we have 20,000 genes in each and every cell came from this huge project called the Human Genome Project. Washington University was one of the 4 institutions that mapped out this project. It took us about 10 years and $1 billion to $2 billion to figure out the human genome, whereas today we can map out the genes in basically all the 20,000 genes for a few $1,000s. As a matter of fact, very recently, one of the Washington University developed assay to map out the genes, all the 20,000 genes in a leukemia in patients with blood cancers who are approved by the Medicare. And we are excited about the groundbreaking assay we have developed here at Washington University. So really things are moving so forward very quickly to really understand what's driving the cancer and targeting them specifically to the extent possible. So today, many cancers, when we have patients with lung cancer or breast cancer, people today map out the genes to figure out what kind of specific therapies they would need. And so I think that's becoming a routine practice in many cancers today.
Great. It sounds like more reason than ever to consult an expert in that particular arena, one that probably the local generalized oncologist. I can't believe I can even say generalized oncologist today, because growing up, if you were an oncologist, you were a specialist.
Right.
But that's a more reason for that. Okay, well, we're coming up on our time. I'd love to open this up to some questions from the audience. There's been a few that have been raised already. So let's start with that. If you're in the audience and you'd like to raise a question, please do that in the Q&A button at the bottom, near the bottom of your screen, and we will be happy to try to answer as many as we can in the time allotted. The first question that came up is, and this is one I can help with if we need to, but will Medicare pay for second opinions at cancer centers? So I don't know, Dr. Govindan.
I am not an expert on the billing thing issue. We have had many second opinions from patients with Medicare. We have not had any call back from patients that their consultation wasn't paid for, but I want to say the answer is yes. But I'm not a billing expert or if there are any special limitations, but I don't think it's an issue.
Yeah, I can supplement that and say that in a face-to-face second opinion, so assuming the patient comes to the facility of the specialist, that is covered by Medicare and Medicaid. In Medicare, it's a Part B deductible, so there's a portion of it that you'll have to pay as a deductible, but otherwise it is covered. If it's a remote second opinion, the initial opinion is not covered today by Medicare. It should be, and we are advocates of that. In fact, tomorrow, our chief marketing officer and myself are meeting with Paul Sarbanes' office to talk through that. He's a member of the of Congress and a member of the healthcare committee to try to see if we can move that ahead. But as of today, an in-person second opinion is covered by Medicare and most private insurance as well. Other questions from the audience? There's another one that's come in that says, when is the right time for a patient to ask for a second opinion? Is there a matriculation time? Do they need to wait for something to occur, or should they do it right away? Dr. Govindan?
That's a great question. And I think anytime when they start thinking about, are we on the right track? Or when they start Googling and find conflicting answers, or when they feel compelled to check many things, I think it's an important thing to seek another opinion from an expert in the field. I mean, in this day and age, we have a lot of information. There was a time, imagine the time before the era of internet, when you had to go to a library to pull a book and read about a cancer or a specific treatment. It wasn't easy. The information was of the specific knowledge or information, I should say, was within a few specialists or people who are trained in that area. Now you can Google and you can find and know about any disease, any drug, ongoing clinical trials, sometimes even better informed than the physician you're seeing. It has happened on many occasions when people ask questions and the physician said, I've never heard of this drug. It turned out to be a drug early in development. And there are also very active social media groups. So it really lifted the information available to patients and their families, but passing that information into useful bits that are applicable to an individual patient is not easy. That requires significant amount of training, expertise. I always like to quote Albert Einstein, who said, information is not knowledge. While the information you glean from the internet and the Google and the chat rooms and social media are great tools to ask your expert a question, they are not the good way. They're not the appropriate ways to guide your therapy solely, of course. And so that's where I think it's important to have the reassuring presence of an expert who could handle questioning by families and patients. There are many times I sit down and there are a series of questions, patients and the families have taken from the internet, and you sit there and answer those questions. I often tell them that very often the answer may be no, because I've already outlined those treatment plans, and if it is important, I would have covered. But then you have to patiently explain why taking a supplement is not a good idea, or taking this drug is not a good idea. And I think you have to explain to them without getting defensive, and comfort them that they got the right answers to those questions. Anecdotes are very powerful. There are times people in the social media or other places say very convincingly, my uncle took this medicine, so he got better. And while that may have been true, but the situation would be very different. Seemingly similar diseases have different approaches one has to take. So I think it's important for the physician expert to sort this out.
Great. Thank you for that. That's very helpful. There's a bunch more questions, but we've got time for one more. So I'd like to raise it, which is there a situation where a second opinion is not appropriate?
I cannot think of a situation, but there are times when patients are very sick and when they are hospitalized in the ICU, when we face those very difficult situations all the time. And naturally, there are a lot of anxiety to ensure that the right things are done. But in those situations, taking somebody out of a very difficult situation for a second opinion may not be appropriate. And hospital to hospital transfers are possible, and that sometimes is how one can resolve the situation. So you have to take the clinical stability into consideration. And that may be one area where one could harm a patient by rushing to a second opinion when they are unstable. That's one I can think of.
Got it. Thank you very much. Okay. Well, unfortunately, we're at the end of our time. I appreciate all the questions from the audience. Thank you very much for attending. And Dr. Govindan, thank you so much for what you brought to the audience today, what you've helped us to understand, and for all the great work that you do there and the other physicians at Siteman do as well. Thank you.
Les, thank you so much. I enjoyed it very much. Thank you. And thanks to you and Sam and the audience for attending this meeting.
Take care. So the next in our series of oncology webinars will be March 22nd. And we'll have Dr. Schwab from Roswell Park Cancer Center, that's up in Buffalo, New York, speak with us. And then on the 4th of April, we'll have representatives from Memorial Sloan Kettering Cancer Center from New York as well. So we're going to learn lots about cancer during this time. Hopefully, during that time, we'll give you opportunities to learn how to best deal with it if it happens to, unfortunately, God forbid it happens to you or one of your family members, but at least you'll be informed. Thanks again for participating today, and we'll see you next month.